Good afternoon, everyone, and a very warm welcome from Cape Town amidst all the public holidays on this lovely Friday afternoon. I trust you can all hear me and see me, and we'll be starting shortly. Okay, we're just getting a few people into the room. Thanks for confirming, Virginia and Erin. All right, let's get going. So everybody, I'm Nisha Jacob, a public health medicine specialist at the University of Cape Town, and I work with MeSH, the Measurement and Surveillance of HIV Epidemic Consortium, supported by the Bill and Melinda Gates Foundation. And it's my great pleasure to welcome you all to the fourth of a series of MeSH EPI meetings and the first of this year. And the aim of these meetings is to take some time from our very busy service-driven lives to reflect and critically review our HIV data using an EPI lens. And so at our first session in March last year, we gave an overview of the HIV epidemic in the Western Cape province. And our second session in July focused on the role of routine HIV data in pregnancy and vertical transmission. And our final session in October looked at advanced HIV disease. And in discussion with various stakeholders, it emerged that HIV PrEP was an area where many would like an opportunity for further discussion, particularly being a somewhat nascent program in the HIV space. And so consequently, we have speakers from diverse health backgrounds lined up today, followed by a discussion led by expert discussants, all involved in PrEP rollout in different roles. And I'll introduce each of our speakers and discussants as we go along. Unfortunately, we were informed this morning that our speaker from MedScheme will be unable to present due to unforeseen circumstances. So our program will be tweaked slightly, and we apologize for this. Just before we start, a few housekeeping rules. Before you speak, if you could switch your microphone on, and if you're able to, switch your camera on, but please keep your microphones muted and your cameras off during the presentations. The main presentations will be approximately 10 minutes each, with about 5 minutes for questions of clarity. And thereafter, in the second hour of the session, we'll have a broader discussion chaired by Andrew Bull. And should you have any questions of clarity in the question answer time or later during the discussion, please use the raise hand function or type your question in the chat. And please do introduce yourself before you ask your question. So before we head into our main presentations, we have asked Vanessa Timmerman, who's also part of the MeSH SA team, to provide a brief overview of routine PrEP data in the Western Cape Provincial Health Data Center as an introduction to the session and a starting platform for us to incorporate insights and best practices to strengthen routine data. Vanessa is a data scientist at the Provincial Health Data Center in the Western Cape Provincial Department of Health and Wellness with a background in biology, epidemiology, and computer science. She's worked in the health informatics and health system strengthening field since 2003 and has experience in both public and private sector. And Vanessa's current focus areas at the PHDC are to support data integration and to develop reporting tools. So I'll hand over to you, Vanessa. We can see your screen, so you can go ahead.
Thank you very much for the opportunity to give a bit of background to the data. Just trying to get the camera switched on. Just a second. Sorry, Nisha, I'm not able to find the camera one now.
There we go. We can see you, Vanessa.
Okay. All right. So let's get into it. So basically, this is almost hot off the press. This is our first week that we're putting PrEP data together, and we're gonna give a bit of insight in what we can see so far for the province. So Sam has kindly prepared the background just for us so that we have a bit of a sense of what's been going on in the province. So since 2016, PrEP has been implemented at some of the sites in the Western Cape, but mostly by donor funders. And in 2020, there was also a scale-up phase was approved, and they want to get all the sites up and running by March 2023. In 2021, National also updated the PrEP guidelines and withdrew the proposed national register. I think that was part of the initial rollout requirements. And then some of the discussions with all the partners and the facilities was also that the data flow and centralized reporting would be quite crucial in this, so that people could just get a sense of the numbers and how well the program is doing. So where we are at the moment is the basic PrEP elements were set up on St. Johnny for the national reporting. And then PrEP and PHIS systems have been set up so that the facilities can currently capture PrEP data. There will be some ongoing developments as we develop the service and get more into the data. So I think only over the next few months we'll see how things are changing. And I mean, some of the things we're already just thinking of is data quality control measures that we can maybe put in place, reports to just help navigate what we're seeing so far. So this is the data. I've only used the premise and PHIS data for this slide, the data that you will be seeing. And we do see a little bit of data before 2021, but we've just cut it off for now. So it could be data errors or back capturing. I'm not too sure yet, but for purposes for today, we're only using at 2021 and 2022. So we can see quite a nice trend going on with the uptake. The blue ones are the initializations, the first time PrEP starting. So very slow beginning of last year and quite a nice uptake over the last few months, especially this year. There's a big drive to get people onto PrEP. The orange bars are just how many people are getting PrEP per month, and it does include the starters. So those the difference between the two bars are just the people who's getting their repeat meds per month then. So the data also in this slide represent 38 facilities from Metro and 1 Central Karoo facility. If we look at the adherence over time, the picture is not very great, unfortunately, at the moment. So what we're plotting here is the adherence. And what I did just for now is I looked at the number of PrEP dispensings, and then I divided by the number of months you are on PrEP. So if you are on PrEP for 10 months and you got 10 dispensing, then you would have been at the 100% level. So what we see in the beginning, the first few months, obviously, as expected, you'll have the 100% people. They started off on PrEP. But as time goes on, the number of months on PrEP, now we can see the bubbles are getting lower down on the adherence scale. And only a few people left with good adherence over time. So I think there is a bit of work that we'll need to do over the next few months just to reiterate the importance of keeping to a PrEP regimen once you've started. The PrEP conversion, so we can see 60 people at the moment, and that's purely based if we take the first date of when PrEP was initialized and compare it with our HIV cascade, how many people of them have an ART start date after the PrEP initialization date. So 16 people. And then I just plotted the number of collections they've had between the PrEP initialization and when we see them as starting on ART to get a sense of their adherence. So the x-axis is just showing us the number of months between PrEP initialization and ART start, so the time to conversion basically, and then the number of ART dispensing, PrEP dispensings we've seen in that time. So the numbers are low, so it's really that the people didn't get a lot of PrEP dispensings, unfortunately. These are early people who got the conversion within 1 or 2 or 4 months and low number of dispensings as expected. But so it is, I'm not sure if it's maybe just a matter of that they probably were positive at the time of testing and not picked up or something, or in the window period. But the others are probably then high-risk people that unfortunately converted over time. And then just a disclaimer, so I haven't included any pharmacy data in this yet. So the pharmacy data will help us to identify any people on a Truvada regimen and not yet enrolled on the HIV program or anything. So, and we just need to make sure we're not counting those people, since the Truvada combination can also be part of the other ART regimen. So that's where a bit of work needs to go into. I've seen a few HIV positive people with an ART start date before the PrEP initialization date. So that's where the data cleaning and checks are coming in. Did we put them incorrectly on the HIV cascades? So we're just looking into those evidences to understand, is it a true data anomaly, or is it people who have started ART and maybe did not disclose that to the facility when they started PrEP? And that will then be used for the full reporting picture once we've implemented that. So we're really trying to get this done within the next 2 weeks or so, and then the reports will start to go up also on the Western Cape's SPV platform for reporting. And that's all from me.
Thanks very much, Vanessa, for that great overview. And for getting it all together timeously. It's great to see this. Do we have any quick questions of clarity for Vanessa? If so, feel free to pop it in the chat or use the raise hand function. Okay, I don't see any burning questions. So thank you to Vanessa. I'm sure we will carry some of that into the discussion, the second hour of today's session. So I'd now like, oh, I see Brian, your hand is up. Go for it, Brian.
Sorry, I was struggling to find it. They had to raise the hand. Sorry about that. I was just wondering, I know there's still further investigations on the data side, but would the idea be for like that, one of those final graphs, which was showing the seroconversions amongst individuals that engage with PrEP, would that be used as a kind of an alerting system? Will there be further investigations as to what's happened there?
Vanessa, yeah, go for it.
To be honest, I'm not 100% sure yet how the facilities are going to treat the info and how they will be using it, but we are quite open to set up alerts, maybe to those providers or whoever is needed. But from an operational point, I'm not sure yet. I think just because it's so new and not implemented yet on the data centers platform.
Thanks, Vanessa. Indeed, I think this all makes for good, useful points for discussion, given that it's such a new program. And thanks for raising that point, Brian. Hasina, I see your hands up.
Yes, thank you. So we have been tracking the seroconversions from the very beginning of the PrEP program. And we've also had a few Sentinel sites where there's been resistance monitoring conducted amongst the seroconverters. Following the initial sort of assessment of the seroconversions, we've now in the new guideline included a seroconversion form, and that will then be submitted into the adverse event monitoring system to look at whether there is a need to do any further follow-up on the seroconverters. So it is early days. We would have to look at it because I think it will also require a proper system, as well as making sure that we have, you know, looking at what kind of follow-ups will be conducted. So, and we have had some recommendations from the early pilots that we've done that we most probably will want to look at. I'm not sure if that answers the question, but I think there's a lot more work that needs to be done around seroconversion. But just to add that a lot of the seroconversions that we've picked up has been in the first month of PrEP initiation. And it could very well be that these people were already seroconverting and it wasn't picked up during initiation. And we do a follow-up HIV test in month 1 to be able to pick that up so that we don't continue people who have already seroconverted on PrEP. Thank you.
That's really helpful, thank you. And I imagine further investigations that could potentially, if you have access to them, include an acute test or a recency test to see if that hypothesis is backed up. But thank you, that's really helpful.
Thanks very much, Brian. And I was going to introduce Hasina a bit later in the program, as Hasina is one of our discussants, but maybe just to just for some context, Hasina is working as a senior technical advisor at the National Department of Health and is very involved in the implementation of PrEP. So has a wealth of experience and insight, which we will delve into a bit more during the discussion. I'm delighted to see that there are quite a few questions in the chat, but I think in the interest of time, we're not going to address them now, but I think we'll carry them over into the discussion. And Vanessa, if you can have a quick look, there are some very practical questions that could be answered in the chat itself. But I think the meatier questions we'll hold on to for the discussion in the second hour. So many thanks again to Vanessa. Our next speaker is Lisa Jamison. So I'd like to welcome Lisa, who is a biostatistician and health economist working as a senior researcher at the Health Economics and Epidemiology Research Office based at Wits University. Welcome, Lisa, over to you.
Thank you, and thank you again for the opportunity to present. Can you see my title slide?
Yes, we can see it.
Okay, great, thanks. Yeah, so thanks for that introduction. I just wanted to present a snapshot, some key results of some of the work we've been doing and modeling the cost and impact of PrEP in South Africa. And I've structured this presentation separating out the two interventions that we looked at, which is oral PrEP as well as long-acting injectable cabotegravir. Just to give you a quick context of where the HERO sits in terms of our main aim, which is our policy-driven research. This is just a schematic showing you basically our involvement in what we are part of and what we do and how this translates from the modeling results. So specifically on HIV planning and budgeting, of course, there's other diseases that we do tackle, but for the purpose of this, HIV, so we would have the epi model estimates that we use, and once we combine this with the cost estimates that we developed, so the cost of the HIV program as well as new interventions, we can translate this into cost effectiveness and of course optimizing our interventions and target population, which of course feeds into a whole bunch of other activities that involves the National Department of Health, their policy guidelines, their plans, goes down to provincial plans as well as actual implementation, which hopefully leads to creating more statistics that can go back into the models. So just this cycle of activities which is ongoing and which we want to contribute to. So quickly on the work we did on the oral daily oral PrEP. This is work we published early 2020. And the main questions we wanted to answer back then was what is the cost and impact of providing daily oral PrEP on different populations in South Africa, and then how does the cost effectiveness of oral PrEP change if we can target those at highest risk of HIV? Quickly, I might go quickly through this because of time, but we modeled oral PrEP to different target populations, each in turn. This included young women, young men, adolescent girls and boys, pregnant women, all that had assumed coverage level of 18% and female sex workers at 30% and men who have sex with men at 54%. Just to say that these assumed coverage levels were based off the early implementation data of PrEP uptake. We then, in this analysis, further included sub-scenarios where only the high-risk subpopulations were selected to initiate PrEP. The idea being that people can self-select themselves into the PrEP program based on their high-risk profile. And some further assumptions is, at the time, we assumed that people would be on PrEP for an average of 2 years, and PrEP effectiveness was between 65 and 85%, depending on the target population. For the cost, I don't want to linger too much on the cost aspect, but just to say that we estimated the cost of PrEP provision based on ingredients-based costing, but also included data from not just the guidelines, but also resource use data from implementation and demonstration projects. And this cost was designed to align with how PrEP would actually be rolled out in primary healthcare sectors, primary health clinics. So it would be the lowest staff cadre, include generic drug prices, that we wanted to be as complete as possible and include the cost of demand creation and training as well. So what we found with this analysis was, of course, we get different levels of impact depending on the population that we target. But the more important thing is if we can target those at highest risk of HIV who carry the burden of the disease, and these are the dashed lines that sort of appear. If I just toggle back and forth, you can see the highest burden of HIV are carried by the people at highest risk of HIV, at high risk, essentially. But of course, because they are a smaller population, if we can just target the high-risk population, it's a smaller group of people, you're preventing much of the HIV infection for the least amount of cost possible because it's a smaller population. And in turn, this can translate into cost savings over a long period of time. Of course, over the 20-year period that we modeled this for, we don't see cost saving over the 20-year period. It will be beyond that. But this, what I'm showing you is a table showing the incremental cost effectiveness ratio. So this is the cost per HIV infection averted, and it's sorted from the most cost effective to the least cost effective. And of course, we can see that those high risk populations are the most cost effective populations to target in terms of PrEP, targeting PrEP and which population should get PrEP. So our main conclusions from this work was, though PrEP was costly, provision to high-risk groups will be more cost-effective, and this is all based on this assumption that self-selection is successful. So it is very important this assumption holds. We do have some preliminary data to show that those at highest risk in female sex worker and MSM populations tend to enroll into PrEP programs. So this was our initial work, and the more recent work involves the long-acting injectable PrEP, so the cabotegravir injection. Many of you, I'm sure, are well aware of the results that HPTN released, I think, late 2020, which showed that long-acting injectable cabotegravir, which from now I'll just refer as CAB-LA for short, was found to be superior in preventing HIV, so superior that they stopped the trials early and ended the oral PrEP arm, so people could go onto CAB-LA if they preferred. But in comparison to oral PrEP, which is already an effective prevention method, CAB-LA reduced the risk of HIV acquisition between 66 and 89% compared to oral PrEP. We also know there are some preference studies, some even in South Africa, which showed there was a stronger preference for injectable products compared to daily pills. So CAB-LA is a really good candidate for HIV prevention in future. And what we did with this analysis was model, similarly to oral PrEP, modeled the impact and cost effectiveness over a 20-year time horizon. And the main aim was to, because CAB-LA is not on the market yet, we wanted to know at what price should it come onto the market to make it as cost effective or more cost effective compared to oral PrEP, which is now our standard of care PrEP intervention. And slightly differently to what we did with oral PrEP, where we looked at separate target populations, we now had a packaged intervention to all the target populations listed there, where we scaled up both oral PrEP and then CAB-LA in turn, and then compared impact and cost effectiveness between these over our baseline scenario. So this is a very, very busy slide. But just to say that we had these three main scenarios of scaling up oral PrEP, Care-Ballet, and in two Care-Ballet scenarios. With Care-Ballet minimum duration, sorry, my laser's going AWOL. With Care-Ballet minimum duration, the main, I guess, similarity between that and an oral PrEP scenario is that we assume that people would be on the PrEP program for the same duration of time. Whereas with a maximum duration scenario, we assume people would be on the Care-Ballet program for longer. It's somewhat reflecting this idea that people have a higher preference for Care-Ballet. We also had different coverage rates, again, assuming a higher coverage in Care-Ballet than an oral PrEP, again, reflecting the higher preference. We did a bunch of sensitivity analysis behind this as well. But overall, a lot of the benefit of Care-Ballet is because it's an injectable, a long-acting product. You have this additional protection once someone leaves a PrEP program. So, you get, because it's an injection, they have another 3 months of protection after they leave, essentially. And effectiveness assumptions behind these oral PrEP is the same, 65 to 85% as before, but with Care-Ballet, in comparison to not having any PrEP product, you're looking at an effective 95% effectiveness for people on Care-Ballet and preventing HIV infection. Again, not to linger on the cost all that much, but just to say that we assume the cost of services, so everything else, excluding the drugs, essentially, are going to be the same between oral PrEP and Care-Ballet if you're on the program for the same amount of time. And they do work out quite similarly. So needless to say that the impact on HIV would be much greater under the Care-Ballet scenarios. It is it's a more effective intervention, as well as slightly higher coverage levels that we assumed. And our main, so between 3 to 5-fold higher impact on averting HIV infections over baseline if someone was taking Care-Ballet compared to, well, if a group of people were taking Care-Ballet as compared to oral PrEP. And our main, the main goal of trying to estimate this threshold cost, what we can see, again, this is a very busy slide, but just to give you an idea, just to focus your attention on this, which is our incremental cost effectiveness ratio. We looked at both cost per infection averted and cost per life year saved. And what we found that is the cost of Care-Ballet the cost of Care-Ballet per injection cannot be more than 2 times the cost of oral PrEP for the equivalent 2-month period in which the dosage is given, right? So Care-Ballet cannot cost all that much more to oral PrEP for it to be as cost effective compared to oral PrEP. And from this, we concluded though Care-Ballet is highly effective in preventing HIV transmission. We estimated a 3 to 5-fold increased impact on averting HIV infections and AIDS deaths over a 20-year period. The cost of it needs to be less than 2-fold. We can estimate an exact price on this if we back solve for the cost of the HIV program. And so the cost of Care-Ballet needs to be somewhere between $9 and $14 per injection, depending on the comparison in the scenario. And this actual price doesn't change that much in our sensitivity analysis. It's pretty robust if we vary some of the key parameters as well. And this is in stark contrast to the current listed US price, which is around $3,700 per injection. Of course, we cannot compare directly between countries, different, and this is a drug that's patented, that's got patents until 2031, I believe. But, we get this result because our cost of oral PrEP is so low, and that's what we essentially are comparing this to. And our cost of oral PrEP is so low because of our successful ART program and generic drugs. But this is not unique to South Africa, and this is in other low and middle income countries where they also use generic oral PrEP, this is also going to be a problem. So our conclusion from this result is for Care-Ballet to be financially feasible, Care-Ballet must be reasonably priced. And then lastly, our data needs, of course, doing this, we do know where some of the needs are, where the gaps are in doing this, and where the weaknesses are in some of our data. So I thought I'd sort of put at the end of this presentation a little shopping list of what, we think would, we've got what we think could be improved upon, or what we need additional data of in terms of modeling PrEP. Just to say that this, we do need continuous monitoring, not just of these individual metrics, but also, for different target populations and different geographical areas as well. We need to better understand uptake rates of PrEP. We do have some idea of this, but across the different populations and geographical areas, we need to understand the determinants of PrEP uptake and characteristics of PrEP initiators. We like Vanessa presented earlier, some of the adherence rates are much not as great as we had hoped, but we would need more information on how this varies across different populations, and what factors affect PrEP adherence would also be important to know. Cycling on and off PrEP, also kind of related to the last 2 points, would help inform duration on PrEP. Periods of risk are also something to consider, since people aren't always at high risk of HIV. The impact of PrEP on condom use is something we do have an estimate for, but it's only from one study. So that is something that we would really like to have more data on, to make that estimate more robust for the modeling work. And going forward, not just for injectable PrEP, but for any other PrEP intervention, that is coming. There's an implant. I think there's about 30 other PrEP drugs and modalities, I guess, on the way. We would, really need more of an idea of the preferences of injectable PrEP. There is some data, like I mentioned, there are some acceptability and preference studies, but they aren't done across all populations and geographical areas. And then, of course, the implementation of PrEP will evolve over time. And so with it, made some of the metrics as different, different ways of implementing PrEP are developed. And so it's important to keep track, not just, once for, but, continuously for all of these. And so, thank you. That is the end.
Thanks very much, Lisa. It was a very interesting presentation, and I really like this slide that you've put up here with the data needs, very useful, and I hope will stimulate some discussion as well a bit later on. Do we have a bit of time for one question? I think one quick question. Are there any burning questions of clarity for Lisa? Ushma, go for it.
Thanks, Lisa. Really interesting presentation. Thanks. I just was looking at this last slide on data needs. Would that also, in terms of, new products, very often signals of new risks, new adverse reactions, particularly more infrequent adverse reactions come into being. So I would think that the data needs would also need to include any severe or serious reactions and the cost of management or monitoring for those. Does that fall under any of these categories, or would that be something different?
That is a very good point. I do think that is something that needs to be collected. I generally think that gets done at a trial phase. Of course, trials tend to be a bit different in real life. So I do think that is important to continue to be collected. And I think some of this does get done in post-trial access, post-trial implementation studies. Important point. Yes, I do think it should be included.
Yeah, just to clarify that usually clinical trials are too small to pick up these.
Yeah.
And that you need proper numbers and information on that. I mean, most of the antiretrovirals signals we've detected post-marketing. Thanks.
Yeah, good point. Thanks.
Hasina, I see your hands up.
Yes, thank you. So the adverse event reporting is included in the routine adverse event reporting system. How effectively it's being reported, I think that's something that we need to work on and make sure that it's done very systematically and it's followed through. So it's a very valid point, Ushma. I think that's something that we need to really look at strengthening as part of the routine implementation, because, you know, it is quite important that we do follow up any adverse event. Thank you.
Thanks, Ushma and Hasina for those, Ushma for that insightful question, and Hasina for those comments. Thank you very much. And a very big thank you to Lisa for a great presentation and a good overview. Thanks very much. I'd now like to welcome our next speaker, Kate Rees. Kate is a public health medicine specialist at Anova Health Institute and the Wits University School of Public Health. Kate has been supporting, sorry, I think we just have some interference. Okay, great. So Kate has been supporting the delivery of HIV treatment services at Anova for more than 5 years. And this work includes evaluating programs and implementation research focused on the use of routine data to improve HIV care and treatment. We're really looking forward to hearing from you, Kate. And we can see your screen.
Great. Thank you, Nisha. And thank you for having me. It's lovely to be here. So I'm going to go over a few kind of operational insights and some experiences or lessons that our PrEP teams have asked me to try and convey. And then look a little bit at our program data and 1 or 2 cases that kind of show the direction that we're trying to move with our PrEP implementation. So firstly, Anova, just for those who don't know, Anova is the PEPFAR district support partner for Johannesburg and Sedibeng in Gauteng, for Capricorn and Mopani in Limpopo, and for Cape Town in the Western Cape. So as the DSP, Anova supports the Department of Health to provide PrEP to the general population in facility settings, so at health facilities. With the exception of Limpopo, where Dreams partners provide PrEP in the community, but PrEP in facility has not been approved and is not currently really provided. We also have a key population program in Cape Town, a really long-standing program that's been providing PrEP to MSM for a long time, and we've got a wealth of experience there. So our target populations are quite interesting. Although the Department of Health provides PrEP to all people at substantial risk of HIV, our USA targets are for adolescent girls and young women only, and so that's an important contextual factor. And we do also have a specific program targeting men, our Health for Men program that also provides PrEP to men. And then just a reminder that there are other partners as well providing PrEP in these districts, for example, specifically to key populations or in community settings. So I just wanted to show the 2021 guidelines, the national guidelines that give a minimum package of service that all facilities should have healthcare workers trained in PrEP and should be able to provide PrEP. And then it shows, it lists the people who are considered to be at substantial risk of HIV infection. And if you look, we have kind of all the usual suspects there, but also individuals who recognize their own risk and request PrEP. So important just to see there. And then box 1 shows a bit of a risk assessment for serodiscordant relationships. And then just to highlight that I'm sure Devorah will go into more detail about the pregnant and breastfeeding women in these new guidelines. So these really nice infographics came from a Becca Cisa article, and this shows the national picture for context before I dive into Anova. So this is National Department of Health data, and you can really see the scale up there around 2020 and then 2021. Although if you consider the numbers that people have been hoping for globally with PrEP, you know, it's still low numbers. And then this looks at the different provinces, and the percentage there is the percentage of health facilities that are providing PrEP. And you can see the kind of earlier adopters there in blue, KZN and Mpumalanga, Gauteng and the Free State, with the majority of their primary healthcare sites providing PrEP. And then the slower or some, to some extent, not yet implementing Limpopo, Northern Cape, and the Western Cape. And we know that that's changing in the Western Cape as we speak. So looking at the national kind of age and gender picture, we see that women aged 15 to 24 are the largest PrEP user group. And that, they have obviously been specifically targeted because of the incidence rates in those groups. But they didn't really mention in this article how the funding has shifted that, but I think it is an important factor. So how is PrEP actually provided within health services? One of the questions that we continue to ask ourselves, and I think the national department and other departments of health ask themselves is, should PrEP be offered in facility or community? Of course, it's both, but what is the balance? And for which populations? And we think that especially for AYP, adolescents and young people, the community has a lot of advantages. People are not in the clinics a lot. They're more comfortable in those settings. So it's important for us to bear that in mind. And we think that ANC is a particularly important in-facility service point for PrEP antenatal care. So ideally, within facilities, we'd want PrEP integrated into sexual and reproductive health services, HIV testing, index testing, antenatal services. But we experience quite a lot of challenges with that integration. And Ben Brown used this term, the artification of PrEP, which I really like, which kind of talks to how there isn't a distinction clearly in people's minds between PrEP and art, and the flow of clients and the language that we use is kind of subsumed into art instead of PrEP. So some of the barriers to the provision include that we really have found that we need dedicated staff to offer and counsel for PrEP. And especially with adolescents, it's really important that peers are involved, but the same for key populations. And then there's a requirement for NMOT training to prescribe PrEP, which means that the pathway and staffing for PrEP then tends to overlap more with ART services than the service entry points where we really want to target people. And it also leads to stigma at times when there's this poor differentiation between PrEP and ART amongst the healthcare workers and the clients. Clients don't want to feel that they're taking HIV treatment. So our current service delivery challenge is, how do we integrate PrEP into antenatal care for pregnant and breastfeeding women? As I've said, it's a really important service point, but the antenatal services are generally staffed by nurses who are not all NMOT trained, and they're not often employed by DSPs. So it really requires full Department of Health buy-in to implement across those points. So just some of the things that people have picked up about attitudes to PrEP. I think we all know that prioritization of prevention is often difficult in health services, and we still need quite a bit of advocacy with policymakers and healthcare workers. And I think we've seen with the the inclusion of pregnant and breastfeeding women in the guidelines, what effect that advocacy can have. So we need to continue with that. And then the demand creation for clients is still considered to be an important gap, where most of our programs, when clients come in and they start talking to them about PrEP, it's very often the first time they're hearing of it, and which makes it a more difficult conversation. And then how do we think about risk? So we heard now from Lisa why risk is so important. But this risk assessment has actually in some cases become more of an access barrier than anything. So it's intended to help us identify who would benefit most from PrEP and who we should offer PrEP to, but sometimes it becomes almost a gatekeeper. And then with our adolescents and young people, risk perception is a specific challenge. How do we convince adolescents that they may be at risk of acquiring HIV when we know that adolescents don't tend to see their own risk? And then lastly, changes to risk over time and cycling on and off are not always well understood. And so the healthcare worker expectations and user experience don't always match up in terms of kind of ease of cycling on and off, ease of accessing PrEP for long periods, and so on. So how do we monitor PrEP? So TIER is used as the primary system in most of the country. There's a PrEP module, and data is captured from national registers into TIER. In Cape Town, the city uses Premise, and at the moment we're reporting in metro sites from national registers. And we heard from Vanessa about the kind of progress there. And that's definitely all I'm prepared to say in this room full of experts about the PHDC. But we do have some challenges with the tier PrEP module, particularly around persistence. We struggle to really monitor persistence, and we're unable to capture cycling on and off, which we know is normal. And we also unable at this stage to identify pregnant and breastfeeding women, which we're struggling with. So how do we monitor this persistence? And I'll share later one of our kind of Band-Aid solutions. So I'm moving on to our program data now and looking at what does our program data show. These two figures show new initiations. On the left, it's all of the districts. So it's Cape Town, Sedibeng, and Johannesburg. And quarterly, you can see there the kind of growth in the initial scale-up period and kind of getting our reporting together. And then a dip in December. And we always see our dips in December, but it's also related to DREAMS funding changes and other reasons. And then you can see that cumulatively we've initiated or we've reported on about 26,000 people. And on the right-hand side, you can see the different districts, how Johannesburg was the first to start implementing, and then Sedibeng came on board, and Cape Town with the kind of slow uptick in the recent quarters. And now we look at the different population groups, and we can see the highest number of initiations in blue there in the adolescent girls and young women. But we still are initiating kind of more than 3,000 men and women over 25 years per quarter at the moment. So this data, we're moving on to the kind of earlier piece of the cascade and trying to have a look at uptake. And if you look, just to orient you, the red bars are people who are eligible for PrEP. And then the gray bar is people who have actually initiated PrEP, and then the percentage is the percentage uptake. And on the left of each of the figures, we've got Cape Town, and on the right, our combined Gauteng program. And the first figure is all ages, and then the second is the AGYW, and the final figure is men. And I think you'll immediately notice that we have some challenges with reporting uptake. And part of that is to do with kind of reporting from PrEP specific service points, so that once you get to the service point, you're already kind of eligible and interested. And part of that is also an expectation that 100% of eligible people will take up PrEP. And so we've had some problems in old iterations of reports where they actually ask you to account for that discrepancy. And so it encourages the skewed reporting picture. But what we have seen in a program where we're confident in our uptake data in our Health for Men program is that it ranges between 30 and 35%. So looking at the white blocks then, the white blocks are giving more of a picture of coverage, comparing the number of people who've initiated PrEP to all the negative HIV tests that we've reported in that period. And so we see that if you look on the left, the first figure, in Cape Town, the coverage is about 0.5% of all negative tests, and in Gauteng, about 1.3%. And of course, I'm not suggesting that we should be at 100%, but it's just to give an idea. And we can see that Gauteng obviously would be higher with more advanced program. And I think what's interesting is that if we look at the adolescent girls and young women and the men, it's actually fairly similar coverage in terms of the tests. So not reaching the men with PrEP, as we saw with the national picture, we're probably not getting them into facilities and testing for HIV. So I think we'd have to look at how to reach them with that one, in the community as well. So moving on to persistence or return, we haven't been monitoring this kind of in this way for that long, since November. So we've got data since November, and we've got 4 data points for the 1-month return in Johannesburg. And we've got all clients there in blue, and then the adolescent girls in red. And the November to December means they initiated in November and returned in December. And we can see that overall, our 1-month return is at about 65%, with the adolescent girls and young women a little bit lower. And it's just important for us to remember that this 1-month return is an important point to monitor. We can't just monitor initiations because maximal protection in women only occurs after 21 days. So we're not going to get much of a public health impact just with clients taking PrEP for a few weeks. And it also really makes you wonder about, long-acting PrEP. If we could have it, what would the changes in these patterns be? Looking at the 4-month return, we only have one data point for that at this point, but it's at 50% for all and quite substantially lower for adolescent girls. So the seroconversions, we don't have a lot of, in-depth data, but what we know is that over the past 18 months, we've recorded 20 people testing HIV positive, 6 men, 6 young women, and 8 other women. And if we use our PrEP current indicator, which should be a proxy for all people receiving PrEP, we get a kind of 0.03% to 0.05% per quarter. But we don't really have enough information to assess whether these were actually missed acute infections or whether clients were adherent or not. So that's something we really need to figure out. So finally, I just wanted to show 2 kind of cases of work that we're doing. The first is at a CHC in Diepsloot in Johannesburg, where we are capturing our kind of patient PrEP records. So from the medical record, we're capturing the whole PrEP journey into a REDCap database to try and give us a clearer picture. We've captured about 250 records. About 3/4 are women, and interestingly, a few are pregnant, even though we haven't really scaled up offering PrEP to women. So we could assume that might mean that there are pregnant women who are wanting PrEP and are kind of demanding it even before we offer. And then we've seen 2 seroconversions, one at the 1-month visit and one at the 3-month visit. And we see the return rates there at about 50% for the first visit. And by the time we get to 3 months at about 30%. And then by the time we get to 6 months at about 11%. So we really don't have a lot of long-term users of PrEP in our general facilities. So finally, index testing and PrEP messaging. So we think, using this messaging around PrEP, around the opportunity to prevent HIV is really important. And we also think that index testing is a really important entry point to identify people at substantial risk of HIV. So this is specifically a project that's being done in Sedibeng, where they've already tested the contacts of index clients, but they're now calling them back a year later to retest them. So to offer them PrEP and retest them. And what we found was then in 1 quarter that the team called more than 1,000 people, and about a third, just less than a third, came in to be retested. 14% of them were positive, so not an insignificant number, and about 36%, so more than a third of those who tested HIV negative initiated on PrEP. And you can read the entry line there, but it's, we really want to focus more on this message that HIV services are not, we don't only have this HIV service that can test you positive and put you on treatment after the fact and this doom and gloom, you have to be on treatment forever, but we also have this opportunity to test you negative and then try and prevent HIV infection. Thank you, and I've just put the names on the presentation of some of our PrEP leads who are doing all of this work. In case any of you would like to contact them at any stage.
Thanks very much, Kate. That was a very clear and comprehensive presentation. Thank you very much. Colleagues, in the interest of time, I think we're going to hold off on questions of clarity now and rather put them on hold for the broader discussion, just so we can give sufficient time to our final speaker for this session, and that is Devorah Joseph Davies. So I'd like to welcome Devorah, who's an associate professor of infectious disease medicine and epidemiology at the University of California in Los Angeles and honorary associate professor at the University of Cape Town. Devorah's research focuses on how best to prevent and treat HIV and other sexually transmitted infections in periconception, pregnant women and couples, as well as other vulnerable populations. Most recently, she's examining the combination of behavioral and biomedical approaches to HIV prevention among vulnerable populations, such as PrEP in pregnant and breastfeeding women. Thank you for joining us, Devorah, and over to you. We can see your screen.
Good afternoon, everyone. Thank you, Nisha. Thank you, colleagues, for the invitation to talk today about our work integrating PrEP into antenatal care in Western Cape. I'll present some of our insights from our research, including uptake, persistence, and outcomes. I'll go over the background quickly. I think that the background has already been addressed by the previous colleagues. Some modeling of the impact of PrEP on EMTCT, and I think that Lisa also presented on this earlier in terms of the impact of providing PrEP to pregnant women. Guidelines in South Africa, our research, barriers, opportunities, and then on implementation science that's ongoing in Western Cape. So we know there's a persistent high HIV incidence in pregnant and breastfeeding women, and the risk of vertical transmission is high in acutely infected women. On the right here, you see the new vertical HIV transmissions across the globe, and in dark red at the top, 35,000 in 2020 infections were acquired if the mother seroconverted during pregnancy and breastfeeding. Women are at substantial risk of HIV infection during pregnancy, and they require a combination HIV prevention, including PrEP, counseling, testing, and HIV self-testing as well for partners or index testing. Oral PrEP is safe and effective at reducing HIV, but PrEP remains limited in pregnant and lactating women at risk of HIV in South Africa. Here we use some data on high HIV incidence during pregnancy. This is a forest plot of a meta-analysis that was done in 2020. And I circled some of the studies that were done earlier from South Africa. And in the random effects model, you'll see that the HIV incidence from 37 studies was 3.4 per 100 woman years in pregnancy, 3.1 during breastfeeding, and combined was 4.6 per 100 woman years. In a recent study in Cape Town, colleagues found that the postpartum incidence was 1.9 per 100 women years. It was highest in the first 6 months postpartum, which is 2.7. And so really highlighting that it's not just pregnancy we're talking about, but early postpartum as well. We conducted a modeling study in 2019 with Lee Johnson and other colleagues, and found that in the absence of PrEP, there would be about 90,000 new infant infections in the next 10 years. And you can see here on the left is the reduction in total HIV transmission in yellow. And there's a conservative scenario on the left and an optimistic scenario. And our model estimates that we can reduce incidence by 48,000 infections in the conservative scenario, in which just a subset of women took up PrEP, and 136,000 in the optimistic scenario, which is in which most high-risk pregnant women and postpartum women took up PrEP, similar to scenarios in the female sex workers and in MSM and adolescent girls and young women. And something to highlight just with these models as well is that oftentimes we're talking about overlapping populations, right? Because adolescent girls and young women are oftentimes the ones who are getting pregnant. And so in our population, for example, half of the population is less than 25 years old. And so we really just talk about adolescent girls and young women, including when they become pregnant and to postpartum period. So here are the new guidelines, and Kate presented on this as well. So the new guidelines, which are updated, include pregnant and postpartum women and breastfeeding women. However, the implementation of maternal PrEP programs remains largely limited to demonstration projects or clinical trials. I'm happy to see that there's some examples of some pregnant women starting PrEP, but the training to include pregnant and breastfeeding women hopefully will start soon, led by the National Department of Health and the provincial departments of health as well. So our team has been conducting research in this field for the past few years, along with colleagues in Kenya, Zimbabwe, Malawi, and Lesotho. We're leading an international PrEP and pregnancy research group of over 50 researchers. We've conducted mathematical modeling, as I presented, healthcare providers' views and perspectives on PrEP, systematic review of PrEP safety, implementation science and PrEP, an ongoing cohort study, which I'll present to you now, and some interventions to improve PrEP and pregnancy, and then a review of new PrEP research, including injectables and other methods in pregnant and breastfeeding women, which was published last month in Lancet HIV. So the first question, one of the first questions we asked are providers ready to provide PrEP and antenatal care? We conducted interviews with 35 antenatal care providers and 2 midwife obstetric units, and fewer than 50% had heard of PrEP. Many misunderstood that PrEP was PEP, and most described inaccurate information about safety, effectiveness, and lack of clinical detail. And this study was done in 2019, but now that we're rolling out PrEP in several different clinics, we see that this misperception or this misunderstanding about safety and effectiveness, especially in pregnancy, persists. And the lack of clinical detail, that people still think that a doctor needs to provide PrEP, et cetera. And so the barriers include healthcare barriers and training barriers, but also the belief that partners need to agree to pregnant women taking PrEP, or that PrEP may be unsafe in pregnancy or in lactating women. Facilitators included good knowledge about serodiscordancy, so everyone we spoke with had seen a woman that had seroconverted during pregnancy, and the desire to prevent incident infections and vertical transmission. But really, we're highlighting the need for training of antenatal staff to deliver and promote PrEP and antenatal care. So we're conducting a study called PrEP-PP, which is PrEP and postpartum and pregnancy, in a community health center with diverse urban township with high HIV incidence. It's an observational cohort of over 1,200 pregnant and breastfeeding women that are 16 years and older. And the councils provide HIV counseling, including PrEP at each quarterly visit. We're following up, so we've fully enrolled as of October last year, and now we're conducting our follow-ups to the end of the year. And we're evaluating the proportion who start PrEP, who continue on PrEP, and risk factors over time. It's a mixed methods evaluation that will allow women to start or stop PrEP at any time. Inclusion criteria is women have to be over 15 years old, confirmed to be pregnant and HIV negative, intending to stay in Cape Town, and without any contraindications to PrEP. They don't need to take PrEP to be in the study, and they can start and stop at any time. We screened over 2,300 women and over 1,200 enrolled. So about 53% of women screened were enrolled. 27% were ineligible and 21% declined participation. 86% of women initiated PrEP at their first antenatal visit, and several more, I think another 10% actually initiated PrEP later on in their pregnancy or in postpartum period. The median age was 26 years and gestational age was 21 weeks at the first antenatal visit. Most were sexually active and most reported recent condomless sex. 60% were unmarried or not cohabiting. A third were unsure of their partner's serostatus. 13% reported intimate partner violence in the last year. 50% reported substance use, mostly alcohol in the past year, and only a quarter had heard of PrEP before. So first, we're looking at correlates of PrEP initiation in our study. Following counseling, 86% of women initiated, and those who were diagnosed with an STI, especially with a point of care STI, so those that were diagnosed with chlamydia, gonorrhea, trichomonas vaginalis, or even syphilis, were more likely to initiate PrEP, which makes sense because we're calling attention to their risk patterns. High internalized PrEP stigma or being married or cohabiting were associated with decreased odds of starting PrEP, even though a third of married women did not know her partner's serostatus. Going on with the cascade, here we can see a similar cascade that other colleagues have presented, where we have over 1,000 women initiating PrEP, and it drops in terms of every month. Continuation was about 70% at 1 month, and of those, about 75% were adherents, saying that they were taking PrEP every day, and you can see how it drops. So 75 to 80% reported missing fewer than 5 doses in the last 30 days, and by 6 months, only 38% were still in the study reporting daily use. Reasons for missing PrEP include side effects, pill burden, forgetfulness, time burden, and fear of safety. So we've used this data to develop interventions, including counseling and differentiated care, especially for postpartum women that don't come into the clinic regularly for their visits. I think, can you mute your computer, please?
Yes,
And
I
here
muted.
you can see, okay, thank you. Here you can see overall the proportion of people that are reporting missing PrEP doses and the reasons why. So of those who experience side effects, for example, 50%, 49% discontinued PrEP. So side effects and pill burden remain significant barriers. So about a third of women on PrEP reported side effects at 1 month, including dizziness, nausea, vomiting, and headache. And remember, these are pregnant women. So women in the first or second trimester had almost 3 times the odds of reporting side effects compared to postpartum women. So there's a real need to address the management of these primarily gastrointestinal side effects in pregnant women starting PrEP. Persistence now, so these are factors associated with continuation and persistence of PrEP, and reporting a side effect at the first month was associated with 0.5 the odds of PrEP persistence at 3 months. In women who missed PrEP, about a quarter stated that it was because of side effects or feeling badly on PrEP, and being later in gestational age, so being greater than 20 weeks gestation and lower educational level, so primary versus secondary, were also associated with poorer PrEP persistence at 3 months. We recently conducted an analysis that is not yet published, but it's under review, of tenofovir diphosphate levels in dried blood spots. So we're looking at objective levels, not just self-reported levels of adherence, which I presented earlier, in women that reported taking PrEP in the last 30 days. And this is a subset of 382 women. Of those women, about half had any tenofovir diphosphate in their dry blood spots, which ranged from 67% at 3 months post-initiation to 31% at 12 months. So you can see very clearly here the data of discontinuation over time, which is really associated with other colleagues have presented as well. And the levels were lower in postpartum versus pregnancy. So you can see the adjusted odds ratio was 0.44 of taking less than, more than 2 doses per week. So postpartum women were less likely to continue on PrEP. And we also found intermittent uses during periods of risk. So women who reported more frequent sex in the past month had over double the odds of having tenofovir diphosphate present. And breastfeeding women also had increased odds of having good adherence. But overall, this analysis really shows low levels of tenofovir diphosphate, low levels of objective adherence, and the need for additional interventions in this population over time. We've also analyzed the birth outcomes to compare with both exposure in orange. In gray is never exposed in our cohort, never took PrEP, and blue is those HIV uninfected in the same clinic. And you can see here there was no real difference overall. This is the composite adverse outcome. So about between 14 to 17% had a composite adverse outcome, including pregnancy loss, miscarriage, stillbirth, preterm delivery. And there was no real difference. We've had difference between taking PrEP and not taking PrEP. This analysis is ongoing and will be presented at the end of the year in the complete cohort. We've had 5 seroconversions identified to date. 1 was during labor and 4 were in early postpartum. All of these women did not have tenofovir diphosphate in their blood and were not currently on PrEP. The strengths of our study is that one of the first studies to integrate oral PrEP in South Africa, and we were integrated into a government antenatal and postnatal service. We included with both women on PrEP and not on PrEP, and we followed up through 12 months postpartum, which is ongoing. The limitations, of course, is generalizability. We were only able to integrate into 1 health facility. We were supposed to be in 2, but because of COVID, it became quite difficult to integrate into another facility. And this might not represent rural perspectives or other regions. We used self-reported PrEP persistence and not objective measures, though we're in the middle of analyzing our objective measures of tenofovir diphosphate. And COVID, of course, the unknown impact on study retention and PrEP continuation and persistence. Is difficult to tell what is the true level versus what was due to COVID and lockdown. We are now implementing an implementation science study now that the protocols have changed and the guidelines have changed to support the government in integrating PrEP and postpartum and pregnant women, and using a RE-AIM framework that you can see here to evaluate reach effectiveness, adoption, implementation, and maintenance over the long term. So we've really refined the PrEP integration and the antenatal care, starting with group counseling and post-test counseling, and giving women more information about PrEP, and then offering PrEP with phlebotomy for creatinine and counseling on daily use, and then refills. And so we've refined all of this and assisted with development of the new guidelines in the Department of Health guidelines. And the objective of our study now is to evaluate the feasibility and acceptability of integrating PrEP into antenatal and postnatal care, including training and mentorship of healthcare providers and patients in high density, high prevalence MOUs and banks. We're starting with daily oral PrEP, but we'll transition to other methods once approved by SAPRA and DOH. So we've done a mapping of the district, we've engaged with the facilities, we've trained the staff, and monitoring progress. And so I'll present some early results as we just started this last month. So since March, we've rolled out in 4 clinics in Guguletu Clinic, Guguletu CHC, Vuyani, and Mitchell's Plain. And you can see here that we've trained 71 healthcare providers and the breakdown of the providers. We have 4 more clinics to roll out in Hanover Park, Crossroads, Langa, and Nzame Zabantu. And the next steps are really to evaluate the feasibility and acceptability of training non-NEMARC PNs and midwives. And that's under review right now with UCT HREC. But you can see here that there's quite a few PNs, CNPs, and midwives that are being trained that are not NEMARC trained. And that is really a significant barrier to the integration of PrEP in antenatal care. So far in the past month, we've initiated 16, the healthcare providers have initiated 16 pregnant and breastfeeding women. And in Guguletu MOU, we continue to initiate 30 to 40 pregnant women per month. And we're transitioning from our research support to implementation science, where the Department of Health will do this as part of the standard of care next month. Facilitators here, we found several motivated staff that are really keen to start implementing PrEP. High demand from clients in certain communities. Vuyani's had great success. The bottlenecks are low numbers of NEMARC trained nurses with high turnover, especially in MOUs and baby clinics. These nurses and midwives are overburdened. And some facilities, PrEP are only dispensed in pharmacies with long queues. And there's really poor integration of maternal child health. So little maternal HIV testing when breastfeeding, there's no folders for mothers, et cetera. There's also confusion with the M&E process, and I think others have stated this about the premise versus tier versus registers, and a lot of the data on continuation of PrEP is limited. The take-home messages from our studies included a high uptake of oral PrEP in pregnant and breastfeeding women, especially those that are at risk. Continuation and persistence, however, have declined over time and really need interventions. PrEP is safe. The pregnancy and birth outcomes don't differ in those who are exposed versus non-exposed. And it's been feasible to integrate into antenatal and postnatal care for women without HIV. Challenges are continuation, limited NEMARC trained nurses and midwives, and providers really need the training support. And the training, the national training is not yet available to include pregnant and breastfeeding women, so we're awaiting that training online and then in person as well. There's also a need to simplify and standardize M&E to integrate PrEP into both ante and postnatal care. I want to thank the team here listed from UCT, UCLA, and Desmond Tutu, and our funders. Thank you very much.
Thank you very much, Devorah. That was some very interesting insights that you shared. And thank you very much to all our speakers for some great presentations today. So our speakers have given us a lot of food for thought, which we can now have a broader discussion about. So I'd like to welcome Andrew Bull, whom I'm sure most of you know. Andrew is a public health medicine specialist at the Western Cape Provincial Department of Health and professor of public health medicine at UCT. And he provides oversight to the Provincial Health Data Center and has long-standing involvement in routine HIV data. And Andrew will be joined by Vanessa Moodley, who is a HAST medical officer working at Services Priorities and Coordination, that's formerly Health Programs at the Western Cape Department of Health and Wellness, for the last 7 years and is also a supernumerary public health medicine registrar. Vanessa works in the clinical governance unit primarily with HIV policy and guideline development and implementation, and was also co-secretariat and co-chair of the provincial PrEP steercom in 2018-2019. And our other discussant, who I already briefly introduced, is Hasina Subeda, who's a senior technical advisor at the National Department of Health in South Africa. And Hasina has been supporting the implementation of HIV PrEP since 2015 and has a wealth of insight into the national rollout. So a very warm welcome to our discussants. It is really fantastic to have you join us today, and we thank you for your time. So Andrew, I'll hand over to you, and I'll also keep an eye on the chat for any questions or discussion points over there. There has been some discussion already and some questions already answered in the chat. So thank you very much to our speakers for doing so. So over to you, Andrew.
Thanks very much, Nisha and all. Can you hear me okay?
Yes, we can.
Great. So it was really fantastic to have such a varied set of presentations. I was trying to kind of summarize for myself what some of the kind of take-home messages were. And I think I heard from the Western Cape that there's an emergence of routine data, which is not something that's been a strength up until now, but focus mostly on registered data, some gaps in the registered data, and we're still not really utilizing medicine data at any scale. That the cost effectiveness is it'll take a long time before PrEP is cost saving, and that the incremental cost effectiveness is scaled according to risk, which makes sense. And that the injectables will have to be not that much more expensive than oral PrEP in order to be similar in terms of cost effectiveness. We saw the functional use of a PrEP cascade from ANOVA and reflection on it, which is fantastic to see, and very rich experiences from the health services about some of the service issues and perspectives on service mismatches around the PrEP program. And I think we just learned that pregnant and breastfeeding women is a very feasible group in which to promote PrEP with high acceptability, high uptake, the same issues around persistence, and not unsurprisingly, that the biological measures show even greater issues around persistence than self-reported. So with that background, I think it would be useful, maybe Hasina, if you could go first and just give your thoughts on what you've heard from a national perspective, and then maybe Vanessa after that. Thank you.
Thank you, Andrew. Sorry, I'm not going to put my video on. I just my load shedding is a little bit of a it's making my signal a bit unstable. Can you hear me clearly?
Yes, we can.
Okay, great. So there's a few things that I want to just pick up on, that were raised in the earlier presentations that I thought may be quite useful just to share with the colleagues on this call. I think the first thing that I want to highlight is that we actually have a national PrEP rollout program, and the decision was taken around 2019, and by 2020, all provinces were informed of the decision to scale up. We worked out a scale-up model looking at the prevalence and incidence rates of HIV and looking at which are the target populations we should be reaching, and in terms of which geographic areas. And that really set the scene for scaling up PrEP. In addition to that, the National Department then made available a range of implementation tools, including a target setting tool that goes right down to a facility level to assist facilities to identify the populations they need to reach in terms of HIV testing, in terms of demand creation, and then looking at potential initiation. And with that, we also included the drugs that they would need, the job aids, the training guide. So there's an online training system. And unfortunately, at the time, COVID hit us when provinces were a little bit slow on the uptake. But when COVID hit us, it really sort of stopped a lot of the rollout or hampered the rollout because of the competing priorities with COVID. And also a lot of the people they needed to reach was also affected by the sort of severe lockdowns that we had early in the process of managing COVID. But, you know, having said that, you know, we've actually seen a good recovery from COVID. And in 2021, we actually had over 2,700 facilities that were reporting on PrEP and with 286,000 PrEP initiations. And I think that you know, just showed us that despite COVID, we're seeing good movement. But the other successful factor in all of this is looking at the number of public facilities, primary healthcare facilities that are implementing PrEP. And if we look at, you know, Free State, Gauteng, KZN, and Mpumalanga, over 90% of the public primary healthcare facilities are offering PrEP. We have slightly lower numbers for Eastern Cape and Northwest. Unfortunately, provinces like Limpopo, Northern Cape and Western Cape have really lagged behind in terms of, you know, public facilities offering PrEP. And I think this is something that, you know, we're looking at to look at how do we support these provinces to actually get PrEP up and running in the public facilities and not to have these facilities relying solely on donor funding to implement the PrEP. So having said that, I think the other thing that I just wanted to highlight, and this is something that came up from most of the presentations, is looking at who are we actually reaching and how long people are actually staying on PrEP. And what is quite interesting is in terms of the age band, you know, we can track using the tier data, and we started reporting on tier from about end of 2019, but the majority of provinces really started reporting on tier from April 2020. And what we've been seeing is that the age bands in terms of who we actually reaching with PrEP and the male and female is really exactly where we want to be seeing PrEP being offered. Similarly, when we look at the gender, you know, with the younger groups, we're seeing more females taking up PrEP. And that could also be because, you know, a lot of the donor funded projects that are supporting PrEP implementation in projects have a high AGYW targets. And if we're looking at, as we move along and where we are seeing the general uptake of PrEP in the public facilities, we are seeing many older men taking up PrEP in the age band of you know, the 30 to 40 group. And I think that's exactly, you know, where we want to sort of monitor that we're reaching the right group. And then the one other thing that came up, and I think it also came up from the ANOVA presentation, and to some extent alluded to by Lisa's presentation, was to actually look at, you know, what is the PrEP use pattern. And, you know, we've done an average, and one of the things we need to recognize that PrEP is not art, okay? We're not expecting people to remain on PrEP for lifelong. And people, and the education of the end user to assess their level of vulnerability to an HIV infection. And I deliberately don't want to use the term risk, because it really has certain connotations when we talk about risk. And I think that one of the things that we need to look at is to say, how do we, as part of the implementation process, create agency in individuals that we initiate on PrEP to be able to monitor their levels of vulnerability for an HIV infection and to manage PrEP use accordingly. And because we can't use the same adherence requirements that we use for ART that we use for PrEP. And we do encourage people to cycle on and off as they need to. And I think that is something that we need to look at recognizing in our data collection. How do we manage that? And when we first started implementing PrEP, we started with a cohort tracking system, and where whoever initiates on PrEP basically is given a entry date, and that's the cohorts that they are on. And we use that to track how long people are remaining on PrEP, and then what is their pattern of use. I think that our data systems just need to be able to be utilized better. Definitely from the tier data, we can track the different cohorts, we can track effective use, and we also can track the cycling on and off. And I think that, if we're looking at ART, we do use all of those parameters to measure ART uptake and retention, and we can do that exactly with PrEP as well. So just for, I think those are some of the key issues I wanted to raise. The issue of the NMART trained nurse, which comes up repeatedly. I think the first thing we need to recognize that this is a Schedule 4 drug, and it's registered by SAPRA as such. We don't implement PrEP as a standalone. We implement PrEP as part of a comprehensive package of services. So it's STI screening, it is pregnancy screening, it is looking at management of other health problems. And if somebody, and this is where, if we don't have people that know how to do a assessment of a client who is seroconverting, and that's where we're actually picking up the challenges in some of the early seroconversions, that is what is being missed. And if people are not NMART trained or not competent to monitor and manage somebody on an ARV, we are going to have challenges. So the PrEP training on its own is not a standalone training. It is built on the primary healthcare 101 training, on the NMART training, and the PrEP is an add-on. And I think this is something that we would need to, going forward, look at how are we going to try and manage this in a slightly different way, but ensuring that we don't compromise competence and we don't compromise the quality of the delivery of service. So those are the critical issues that I wanted to raise. Thank you.
Thanks, Asina. And I think let's flip straight to Vanessa, and then maybe if people have questions for, especially the last two speakers where we didn't have time for questions, and also for the two discussants, and then general comments. Over to you, Vanessa.
Thank you. Good afternoon. I'm also going to put my camera off. Just putting it on to say good afternoon to you all. My signal is also a little bit unstable, so I'll just put it off now. So from my point of view, so I'm sitting at the Department of Health, and we've been implementing PrEP initially as a study or as an implementation operational kind of a study, and then at the end of 2019 we were ready to roll this out. And I can give you some insights about the learnings that we had developed over that time period. We looked at different models of demand creation, and remember we were focusing mainly on MSM and on young women and girls. So there was a lot of activity around community activation. There was an NPO partner that was TB HIV Care that was very active in going into communities and actually drumming up support and making it look like something, that was appealing to young people, and actually bringing them to the facilities to start treatment. And that seemed to be quite a popular, it's quite a successful way of creating demand. Whereas with the other other facilities that were waiting passively for people to actually come and identify themselves as needing PrEP, their uptake was a bit slow. The uptake in the MSM clinics also was very good, and that's because a lot of those patients identified themselves as being at risk. So going forward, unfortunately, COVID stood in the way of us rolling this out across the province. And to getting to the point of where we are now, we have just put out a circular that's just come out today, which is advocating for a sort of staged implementation of PrEP, taking into account that there are a number of other service pressures that services have to be aware of. And I don't need to explain those service pressures. I'm sure you all are aware of the impact that COVID has had on our immunization, on our TB, on ART, loss to follow up, mental health, and all those other things. And so the province has decided that the implementation will be staggered. So the idea is about 25% increase over of facilities over each quarter for the next year, so that in a year's time we will be implementing in all our facilities. Then they've also outlined the details around M&E, because that was also important for us. We didn't really have a clear way of how we were going to monitor and evaluate the rollout, and so they've done some work around that. Key things that stand out for me is, of course, the demand creation, and then it's the use of PrEP in pregnant and breastfeeding women, which I think is extremely important and has to be done quite carefully, because it is a group of women who are not just normal healthy women. They are pregnant women, and they might be at risk, and we want to monitor them and manage them a bit more carefully than we do our other patients. At least that's the traditional way of thinking about it. And so we know that they are very much at risk, but the question will be, how do we get them to identify themselves as being at risk? To a large extent, it's going to be provider initiated initially, and we should be looking at those people who are more vulnerable, which is the patients who have partners who are HIV positive, so those in discordant relationships, and those who have a history of STIs and those sort of things. The other aspect that we can tap into is the index case tracing. The province hasn't properly implemented index case testing or self-screening yet, and a circular is about to be issued on that. So that is a good activity that we can harness to promote PrEP uptake as well, now that we're starting on that. And I want to just highlight something that Hasina said, and that is that PrEP is rolled out as a part of a group of services. It's not just a standalone intervention, it's a group of preventive services, and that includes also condom use. And I want to highlight here that this province has a poor history of condom uptake and condom distribution. And I don't say that proudly, but this is the truth, and this has actually declined over this period when we have had COVID. So there are other preventive measures that we also need to upscale. And it's not just PrEP that's going to be the answer to bringing down the risk of seroconversion in our population. And then one last thing from me, and that is about the side effects of PrEP. I don't think we should take it too lightly. I know that it's reported that PrEP has got low incidence of side effects, but one of the things that came out of our learnings was that a lot of patients did report side effects during the early part of during the first month of taking PrEP. And the way that one of our service providers worked on that was to actually preemptively give people something for nausea and some Panado in case they had a headache, and explain to them that you might get this, but here's the medication to take. And that actually reflected in people continuing with their PrEP medication more successfully. So I think that it is important that the staff who are looking after these patients are aware of this, that side effects do crop up, and we would also want them to report on these side effects so that we at a provincial level know what is actually happening out there and if people are actually experiencing side effects. And when we bring in new modalities, we do want to monitor any sort of new side effects that might be picked up as well. So thank you. That's all I have. got to say what from my side.
Thanks very much, Vanessa. So I'm now watching the screen to look for if there are any questions from participants. And maybe whilst I'm waiting for a hand, in terms of identifying own risk and also just looking at how the services have pushed so hard to promote PrEP, can I ask what's happening both nationally and provincially around health promotion using traditional IEC type methods to publicize the availability of PrEP now that it is so much more widely available?
Can I come in, Andrew?
Yeah, please.
Yeah. So with regard to the social mobilization and healthcare user education, we had centrally developed, when we started the process of scaling up PrEP, is we developed IEC materials. And one of the things that we did from the very beginning is that regardless of who was implementing PrEP, the IEC material was fairly standardized and everybody used exactly the same IEC material. We have it translated into the 11 official languages. And I think that was the one thing that was useful, that even though we implemented PrEP for different target groups, we tried not to stigmatize PrEP for a particular group. So, though we used, in terms of adapted the IEC material for the MSM population and for the sex workers and for AGYW, the wording and everything was exactly the same. The only thing that changed was the look and feel of the IEC materials. And that was with the sort of like printed materials and posters and things like that. And then we also developed radio, promotional radio and video clips, as well as we have a PrEP social media and Twitter account, as well as a PrEP website. And I think that all of these resources are resources that, especially the PrEP website, it includes a range of different options that people could choose. So if you're a healthcare provider, you can go to the provider portal and download any of the provider materials. And then there is the healthcare user, and then for the general public. I think and these were made available to all provinces and available to all partners that we're implementing PrEP to utilize. The challenge comes in is that a lot of, though the materials are there, the actual delivery of and putting this material out there does become quite expensive. And so what we normally do as part of any health promotion activity from a national level, we incorporate as part of HIV prevention, the PrEP component as well. But I think that there is a lot more work that needs to be done around social mobilization and education of people around that. But having said that, I think that the critical part of the education of the healthcare user is at the front line, by the frontline healthcare worker, and making sure that people fully understand that. So that is something that, will always require a lot more work. And yes, we have got the tools and we keep adapting them, but I think that we can look at improving them a lot more as well. Thank you.
Yeah, thanks a lot, Hasina. So I popped in a couple of questions as well to ask if anybody on the call wants to comment, and otherwise we're still open for comments or questions. Otherwise, I can add a couple of questions for some of the speakers. Kate, for the persistence that you showed, I think you showed 11% at 6 months. Was that there was only 11% of people who had stayed on PrEP throughout the 6 months, or 11% who had been on PrEP in the 6th month compared to those who had originally started.
The latter, so 11% of people who initiated PrEP 6 months ago that remained on PrEP.
That were on PrEP in the 6th month, but they may have cycled off PrEP and back on.
Yeah.
Yeah. And so I think so the principle being that the cascade must not be you fall off and then you're off forever. It must be almost cross-sectional at every duration. So it might be different people at each duration who are on PrEP at that time of the total who started.
Yeah, yeah.
And then I don't know, Vanessa, if you want to comment on how complete you think the medicine data might be if we were to use it to supplement or as an alternative to actively captured register data.
Hi, Andrew. So we would mostly be using it from the pharmacies, and I think PHIS meds are going to go that route. The premise ones are quite good in capturing the meds. Yeah, but I'm not far enough into the analysis to see how many more people we will get through supplementing with the meds at the moment.
Elsewhere in the country, is there any potential to use medicine data, or are most of these not digitized through something like CCMDD or any other mechanism?
Andrew, can I come in here, Hasina?
Yeah, please.
Yeah. So if we look at the medicines data, and we did explore that, I think that one of the challenges we would have is that we are still using TDF FTC for second line. And you know, at the medicine level, they're not capturing whether the HIV status of the individual. So if you issue a TDF FTC to a client, it could be for treatment or for prevention. And this was one of the reasons why we actually went for the tier approach. So we don't use a register. It's just from the clinical record that it's recorded onto tier. I think there's a different system in the Western Cape, you know, where the register was created. And perhaps maybe one of the things one would need to look at is how does that compare with what we're doing in the rest of the country. It seems to be, you know, they seem to be capturing that information fairly accurately. And what is also quite useful in that system is that, you know, the HIV test, whether it's negative or positive, leads you, if it's a negative test, it then leads you to say, is the client on PrEP? And then immediately you look at the PrEP being as a prevention intervention, as opposed to somebody who would get TDF FTC as treatment. So I'm not quite sure if that would be, you know how that would work in the Western Cape. And I think we just need to understand the data system a little bit better in the Western Cape to see if that is possible. The other question that you raise, Andrew, around the issue of family planning and looking at the linkage to family planning. So where we've integrated PrEP into public primary healthcare facilities, that is where the PrEP is actually being implemented in the consulting room by the primary healthcare nurse. So, you know, I think we just need to look at, I'm not sure if there are too many standalone family planning clinics anymore. I think they are very much integrated, and if somebody goes into the primary healthcare nurse, it's usually a one-stop service, and that is where we've actually been integrating PrEP into primary healthcare facilities. That is the approach that we've been using, and we can share with you the PrEP planning tool, which actually looks at how do we integrate PrEP into our existing services.
Great, thanks. And maybe if I can just clarify, when I refer to registers, I mean electronic and paper registers. So there will be PrEP data captured on tier, premise, PHCIS, I consider to be electronic register data, where somebody's actively registered, kind of indicated that somebody's on PrEP versus inferring it from medicine data. And we have the same challenge about differentiating 3-drug ART or even PEP from PrEP. And I think one needs the HIV status and one needs all the drugs to be able to try and do that. But I think it is potentially possible. I see that, Jackie, you were asking about how much medicine is given out of hand versus through pharmacies. I don't know if people want to comment on that, because it also talks to the potential to use medicines to track PrEP. Devorah, you?
Yeah, no, I was going to say for the MOUs that we work in, most of it is during the consultation. So they use the stock that they have already in the MOU. But obviously we go through the pharmacy. So there is a pharmacy record of the PrEP that's dispensed. We just don't, just like we do with ARTs, it's given through the consultation. So there is a way, I think that is a good idea though, as trying to look at the medicine data to substitute the data to monitor PrEP use over time.
Yeah, so it's given out of hand in the consultation area, but the chart goes back to the pharmacy, so it should still be individuated on a system.
Yeah, correct.
Great.
Vanessa also asked something about risk, and I wanted to highlight that the way that we've identified women is just by offering them more information on PrEP. And what we found, and I don't think I shared a slide on this, but when we compared the data in our cohort of women that opted to take PrEP versus those that did not, women self-selected to start PrEP. So women that had STIs or multiple partners or HIV infected partners who tended to be higher risk opted to start and stay on PrEP versus those that may be lower risk. So we don't think that there needs to be any kind of risk score identification, at least in the ante and postnatal care, is that women were able to self-identify and were more likely to stay on PrEP as well.
Thanks, Devorah. Vanessa?
Perhaps if I can just ask Devorah another question about the study. In terms of stigma by healthcare workers, not talking about stigma for patients, but when we started rolling out PrEP, we noticed that some of the staff at facilities also had quite a lot of stigma around PrEP. So when you did your study, did you have to do any specific training of the healthcare workers around this?
Yes, we have. So as Hasina mentioned, there is a national training. And so what we would do is we would encourage people, we're still doing training. So we encourage all of the healthcare providers to do the national training just to get the didactic information. And then we will go in again and do a more practical training where we address some of the barriers and some of the stigma or other issues that providers might think. And especially in a pregnancy situation, a lot of providers, like I presented, might think that PrEP is not safe or shouldn't be prescribed without a partner's authorization or a parent's authorization. So we addressed some of those barriers as well in the training, as well as reviewing all of the didactic information that's in the national training. So we do an in-person 3-hour training, and there's a practical component to that as well. And then we're also mentoring. So we're going in once a week, both the counselors and our clinicians, to mentor the staff over time. And that's ongoing in 8 facilities right now in Western Cape.
Thanks, Hasina. Did you want to comment on the same point?
Yes, Andrew, thank you. And I think that what Devorah has raised is that, you know, the content of what people need to know to make them feel comfortable about initiating PrEP is there. However, what is very critical in supporting implementation is looking at supporting them to identify how PrEP can be implemented in their facilities and looking at the roles that everybody in the facility plays around this, because it's from the person who's the security guard at the entrance, to the receptionist, to the counselor, to the health promoters, to you know, the person that is then, you know, sort of doing the clinical assessment, and then the M&E staff. So it really is important that it's considered as a, you know, if we're looking at implementation, it has to be part of a much more coordinated approach rather than just training individuals. And this is where going into a facility and providing that kind of support and mentorship is critical, especially. Sorry.
Great, thanks.
Okay.
So not seeing any other hands here, I'm going to abuse the fact that Eric has come into the office to attend the seminar and ask a question from the MSF experience, promoting PrEP in different contexts, usually resource-limited context, more challenged perhaps than South Africa. What has MSF's experience been? Yeah.
Thank you, Andrew, and thanks for inviting me here to speak. Sorry, it was absolutely not prepared, but I'll be blunt and just to try to do a sort of summary of where is MSF experience and what we think about it. So we have, yes, as you say, implemented oral PrEP, of course, condom before since long, but oral PrEP as pilots in different settings in the country of Southern Africa, and including here in Kailicha. Some of the people participating in this meeting have been more involved than me into that. What came out of it, it's actually what was displayed by majority of the speaker, is oral PrEP, speaking about TDF3TC, is there's a good uptake in adolescent and young women. That was the main target. Good uptake, but dramatic dropout. Absolutely dramatic dropout. At 6 months, we had more than 50% dropout, despite all the support we could give, all the adherence counseling we could give. It was very disappointing. And we handed over this Kailicha program to the province, but kept, of course, an interest. There was some light in the tunnel with the intravaginal PrEP, the coil and different methods. Actually, we do not believe, we have a few experience mostly in South America with that in very high risk population. Unfortunately, partner perception there comes in, as we can easily anticipate. And then now comes LA-CAP. LA-CAP is definitely injectable cabotegravir, light in the tunnel, and it's quite clearly superior to oral PrEP, as HPTN 084 showed, and we all know about that one. Problem with LA-CAP now, way forward, definitely it's not the end of the tunnel, but it's an important step. Problem, first of all, and it was mentioned by some of the speaker, is it's definitely not the demand. It's amazing. We always use family planning as the example in a place like Kailicha, where all oral and injectable family planning methods are offered. There is a clear preference for injectable. People, women say clearly, let's go for injectable. So LA-CAP, definitely, we anticipate, we have not yet started, a clear demand for it. And so and demand creation will be central. But one problem is, for the moment, access and availability. Access, price, it was mentioned by Vanessa, I think mentioned it initially. We contacted Viv and they said, well, yeah, the price is $3,600 so similar than the price in the US per injection. So needless to say, nobody is going to implement that at this price. So we need to work on this and make sure that there is alternative, generic alternative. By the way, some work done within MSF and other organizations estimated that it should be possible to produce a generic version at $2.60 per injection. Right? So, well, we've been there already. There's a possibility with competition. And needless to say, South Africa has a role to play there. It's definitely not the end of the pipeline in terms of long-acting CAB. One of the problems is you need to avoid to congest the clinics with people coming there on a monthly or 2 monthly basis. Sorry, it should be 2 monthly to get the injection. So everybody now is exploring self-injection, and there comes this whole research about micro patches and micro needles that they could be self-injected, so that as we do for a long resupply of antiretroviral, to let people have the autonomy despite LACAP. Future of the pipeline, of course, is other, so micropatch, but also implants. There's a backfighting with the story of islatravir implants. We all know about it, but there's definitely other formulation that should be at the end of the dinner. So in summary, there's an opportunity with LACAP. Definitely MSF will do its best to push for it, and many other organizations will push for it to drop the price. And needless to say, South Africa has a major role to play in showing the impact it might have in reducing the incidence of the HIV epidemic.
Thanks very much, Eric. Nice to kind of hear the kind of pipeline thinking. We're almost at the hour, so if there are not any last comments, I think at that point, I'm going to pass back to Nisha to close the seminar. But huge thanks to our discussants. We really appreciate both Christina and Vanessa taking time out of their busy schedules and sharing the very real world experiences, and hugely thankful for all the other responses. Back to you, Nisha.
Thank you very much, Andrew. I'd just like to echo that and thank our discussants and our speakers. A very big thank you to Vanessa Timmerman, Lisa, Kate, and Devorah, and our discussants, Andrew, Vanessa Moodley, and Hasina, for their excellent presentations and discussion points. We really value your insights and recommendations. And thank you to everyone for attending and participating in the discussion, for your questions in the chat and in the broader discussion. We really appreciate it. It's been a very robust discussion. Our next meeting is tentatively scheduled for October this year, and we will send out further details once confirmed. A recording of this meeting will be available on the MeSH YouTube page shortly, and we'll distribute that link for any colleagues who are unable to attend at this time. And we look forward to another meeting and further robust discussions in future. Have a lovely weekend, everyone, and another short week for those in South Africa. Bye.
Thank you, everyone. Bye-bye.
Thank you, everyone.
Thank you.
Thanks,
Bye.
Thank you. Bye.
Thanks, everyone. Bye.